Hello, I'm Dr. Jorge Calzada. Is the audio okay? I'm a retinal specialist in Memphis, and I was asked to talk about how to, what are the impacts, the economic impacts and influence of utilization of MicroPulse laser, specifically in a retina practice. And so thanks for the invitation to AirDex, and thanks for everybody that's here. So these are my disclosures. I've consulted with a number of companies. For the sake of this, I consult for AirDex, which is right there. So why is the discussion of finances or economics in the retina practice important? Well, if you look at what Medicare Part B, the millions, and by the way, this is the number of intravitreal injections, not money. But you can see how since, by the way, this doesn't do anything here. Yeah, because the pointer works there, but not there. So if you go from 2004, if you think about it, Avastin was first brought into utilization around 2005 when it started being utilized more. Since 2004, 2005, we've gone from negligible number of injections to literally millions of injections a year. Now, as you can imagine, this has a significant impact both in the finances of our practices and in the healthcare system at large. Because when you look at the spending on just two specific medications, Eylea and Lucentis, so Aflibercept and Ranibizumab, you can see that you're talking in the billions of dollars. In the past few years, you're talking somewhere around $4-point-something billion being utilized just in pharmaceuticals in our offices. And if you think about it, I don't see this number plateauing anytime soon, because we have more and more diabetics, more and more macular degeneration patients. The ratio of people that die with macular degeneration, with new diagnosis of macular degeneration, this is an accumulated number that's only going to increase. And particularly in this academy, you've seen data coming out from different companies, particularly in the side of geographic atrophy. So assuming that one or two of the medications that treat geographic atrophy get approved in the next year or so, the numbers of intravitreal injections in our offices are going to skyrocket. And the spending on healthcare spending on pharmaceuticals is going to continue skyrocketing. And this is just a reality. I'm not saying that this is bad. I'm just saying this is where we live in. This is the world that we live in. Be aware of it, accept it, and move on forward. And what can we do to deal with that? So what are the economics of retinal pharma? And for those of us that do a lot of this, we kind of know it by heart, but I will argue these points one by one. First of all, value-based utilization questions. What does that mean? Well, what's the value benefit of using compounded bevacizumab versus a branded medication like Eylea or Lucentis? We can argue that point, but the point of the matter is that this is a question and a push that's being put upon us by the world at large, and most importantly by payers, by insurance companies, Medicare. And we're about to have biosimilars. We're already having biosimilars coming into the practice. So this concept of value-based utilization of healthcare. What about safety considerations? Well, what about the quality of the syringes from compounding pharmacies? I don't know about you guys, but I've had plenty of Avastin about 2 years ago that had problems with the syringes that were getting stuffed, and that was a huge issue. And in addition to that, we have issues with supply lines. So we have about 3 big compounding pharmacies right now for Avastin. When one goes offline because there's a problem, we don't have enough Avastin in our practices. And will that change with them? But these are realities of our work. And you have this sort of healthcare system-wide economics of cost and utilization that are growing, as I said, exponentially. So how does that affect us? Obviously, I'm here talking about lasers. But I'm trying to make the point of how do lasers work in this concept of heavy pharma utilization. So what are the issues intravitreal therapy. For good or for bad, I think you'll know them. Particularly in things like diabetes, vein occlusions, you're talking about long-term therapy. Even those medications that last a little bit longer than monthly, you're still not talking about doing one injection a year. You're talking one injection over how many months, how many weeks. What about non-compliance with follow-ups that may lead to vision loss? We all know, we all have patients that are good patients, compliant patients that come in as scheduled and they fall and break their hips. They end up in the hospital with pneumonia. Or I'm sure that you've seen there's a pandemic and they can't come into our offices. And by the time they come in, their vision has decreased, and now we're trying to bring it back around. Insurance companies trying to, I'm not fond of insurance companies, but they play their role and they're trying to decrease the utilization by coming up with systems like prior authorization. Prior authorization, all it is to say, we will agree to you for you to use a certain medication or not. But from our perspectives in our offices, it's just yet another thing to do. Step therapies, how you start from, they say, well, we'll not pay for Avastin. We will pay for Avastin only if you use it 3 times before you go to a branded medication. Insurance copays. I'm going to go these specifics a little bit more in detail. Okay, I was talking about this, but I was going to go into this discussion. So, as I said, external financial pressures on our clinics for intravitreal therapy. So we already discussed a little bit about step therapy. This is when we say, well, I want to use Lucentis, and they say, no, you can't. You have to use Avastin so many times before we approve it. And we will have to approve it with prior authorization. So you need to have someone in your office that dedicates his or her time to just deal with insurance companies so it gets approved. And then are we going to be evaluated by payers to say, well, you're a high utilization person, so therefore we're going to consider you a lesser quality physician than one that treats their patients for less money. That's been discussed for a long time. That hasn't really happened in my experience, but the specter of that sort of tiering of physicians' utilization, I think it's a real specter that may kind of come up at some point. There you go. What about our practice? It's other issues you have to deal with. What about the 20% copays? We all have systems for that. And pharmaceutical companies have come up with ways to support the 20% copay, but it's still an issue that has to be addressed. 20% of $1,500, to put a round number, is a high number. Some patients cannot pay for it, And in our perspective, we're buying for this. So non-compliance with follow-up appointments, as I mentioned. Or how about if a patient has Medicaid? I love Medicaid because they say, yeah, you're allowed to use it, we just won't pay you. And as we are buying these medications, in our practices, so how does this apply? Well, we have the volume of injections is just increasing, and it doesn't seem to be plateauing anytime soon. And as I said, if we assume the approval of 1 or 2 medications for geographic atrophy, we're going to be we're already doing dozens of injections on a clinic day. I don't know where the limit is going to be. Cash flow. As you'll know, our practices need to purchase these medications ahead of utilizing it. So we have to negotiate with our suppliers to say, okay, the insurance company is going to pay me at 90 days, and they're trying to pay me at 120 days if possible, but I'm having to buy this medication. Can I pay you in 60 days and cash flow it and this revenue cycle management? And in addition, pharmaceutical inventory. We effectively have become retail practices where we're selling something and we have to act not as physicians. But it happens, we all do it. But these are realities of the world of intravitreal therapy. So where does MicroPulse laser, in my perspective, comes into this? So and I'm going to talk about on the clinical side and go back to this idea. So the best patient population, at least in my perspective, to bring utilization of MicroPulse is specifically in patients with diabetic macular edema. My preferred patients for MicroPulse are those patients that have macular edema that's focal, usually less than 1 quadrant, particularly more if it's not involving the fovea. These are great patients. We can talk about the settings and how we do it, but what are our clinical goals of therapy? Complete resolution of diabetic macular edema. Notice that I'm not even talking about vein occlusions or dry macular degeneration. I'm trying to just focus on something that's a simple analysis. Complete resolution of diabetic macular edema. long-term response, meaning if I'm going to do this, I don't want to do this once and have to do it again in 2 months, and then in 2 months, and then in 2 months. That beats the purpose, you know. And if you don't get these responses, what I would at least want to see is a significant decrease in the frequency of injections that a patient needs to have, or ability to switch to medications that are perhaps less expensive, less powerful, less issues. Okay. This is a typical example of a patient with focal diabetic macular edema. So this patient shows up in my office, 2020, with quite a bit of, if you see here on the map, quite a bit of non-foveal involvement macular edema. So how do we approach this patient clinically? We can inject this patient with anti-VEGF. We can inject this patient with steroids, and we probably will make the patient better. You know, it probably will work. And you'll inject 3, 4, 5 times, the edema will go away, and then you stop injecting, and the edema will come back. We know that. But this patient had 1 session of MicroPulse laser, and I'm going to move out of the screen. If you see on the infrared, you see those tiny little dots? Those tiny little dots. So when we talk about MicroPulse laser, people, when I first got introduced to the concept of MicroPulse laser, I was told, you don't see the response. And I'm like, that sounds like it's not true. If you don't see a biological response, how are you going to have a biological response? So the reality is that you do see a biological response, but that it's very subtle. But at least it gives me a sense of credibility that there's actually something happening biologically. And the best way to look at it is, just a side note, and I'm coming offline of the economics, but the best place to look at it is on the infrared imaging. So in infrared imaging, you see those tiny little dots. This patient had treatment in there, and that subtlety tells me that I did that MicroPulse laser in there. 3 months later, from treatment, complete resolution of the macular edema. And this patient was followed for a couple years afterwards, maintained complete resolution of the macular edema. I think that's pretty good. You know, I think that there's no magic, but I think that's pretty good. And for the sake of discussions, let me show you a patient that doesn't look at first glance that perfect, okay? Because I'll tell you, so that's the FA at presentation, the angiography. You can see leakage, basically microaneurysms and leakage right above the fovea, with quite a bit of significant involvement of macular edema on the superior half of the macula and foveal involvement. And so this photo here, I want to see if I can show you the dates. This was about a year and change out. So this is quite a bit of time after that. That patient on that first visit, I did 1 injection of Aflibercept, of Eylea, and brought the patient back a couple weeks later, did a MicroPulse laser. That was approximately February of 2019. What happened a few weeks after this? A pandemic hit. And I did not see the patient back for over a year. And when the patient comes back, I'm like, gosh, the patient's going to be bad. So that's how the patient looked after a year and change from the original treatment. And clearly, there's not complete resolution of the edema, but the fovea looks perfect. The edema that the patient has is minimal, but the long-term response is something that I don't think could have ever been achieved with anti-VEGF therapy alone. And what I did to this patient when I saw this patient was, and I saw this patient recently, by the way, I did a little bit more laser at that point. And I said, okay, come back in 3 months. And so I'm trying to make, just for the simplicity's sake, 2 typical examples of patients in which I think that introduction of MicroPulse brought a really good improvement benefit to the patient care. But now let's go back from the perspective of the clinic. How is that good for us? So these patients can be followed back about 90 days afterwards, simply because you know that the response is not going to be immediate. Unlike anti-VEGF therapy that you have pretty quick response, this response requires, 2-3 months to actually see a complete response or something. So I don't have to bring the patient back for a little bit. Of course, the follow-up will also depend on what's happening on the other eye, because usually these patients have bilateral disease. Now, what are the downsides? I want to be objective about this. Well, MicroPulse laser does have a 90-day global period. So that means that if you bring the patient back in that 90-day, you won't have an examination fee. But that's okay, That's in comparison to the sort of no global period, 1-day global period for intravitreal injections. There still requires prior authorization, okay, because you may not get paid. Now, the difference is if you don't get paid, at least you don't have a medication that you bought and used, It does require a capital purchase. So you have to buy the machine to be able to have it available. But once bought, it gets amortized against all the patients that you treat over a long period of time rather than a single injection per visit. Are there patients that we can't laser? Yeah. There's some patients that for one reason or the other, and I'm sure you've known them, they just move, they can't complain, and you don't feel comfortable doing the best laser possible. Or if a patient has a significant cataract or corneal problems and you need good visualization, well, that's a reality. But this is an interesting part about MicroPulse laser that I think is important. It requires us to think. I think so many times as retina surgeons we get too complacent just looking quickly at a scan and saying, there's fluid, inject, there's fluid, inject, there's fluid, inject, and we become a little bit non-thinking people. And I do think that the introduction of MicroPulse laser requires us to kind of think about alternatives and options and whatever. But ultimately the point with this is when administered adequately, it may not be on every single one of your patients, but there are great patients that have great success with these. And so you have, if you think about in the spectrum, you have these patients with severe diffuse macular edema. That patient will require injections, And you have on the opposite spectrum those patients like I presented that have focal macular edema. Those patients should easily be treated with MicroPulse. And there's somewhere in the middle where you begin with MicroPulse treatment. You begin with anti-VEGF therapy. You decrease the edema significantly. And after a few months of therapy, you recheck and now you realize that you have the edema was localized in one specific area. Well, then treat that area and then see the response. And that overlap, I think, is important. But as I said, it does require us to think, not just simply act. What is ultimately my perspective? And this is kind of like my philosophy behind this, that a healthy retina practice should have the ability to use different pharmaceutical products as well as non-pharmaceutical therapeutic approaches. Okay, so I think that I do not like having my hands as a doctor curtailed. I want to be able to have a full menu of options, and that implies to me that on the anti-VEGF side, I want to have Eylea, I want to have Lucentis, I want to have steroids, I want to have Osterdex. I've been using Xipere lately. I think that's great. I want to be able to take the patient to the operating room if the patient has a vitreous hemorrhage and do a vitrectomy. That's involved. But at the same time, I do think that laser plays a significant role. Now, notice that I'm specifically talking about laser in terms of diabetic macular edema. There's no question about laser for PRP and a patient with proliferative diabetic retinopathy can be performed also with the same machine. But in terms of diabetic macular edema, I think this allows us to provide more personalized care, basically look at what the patient has, look at what the patient can have, including the patient's social and economic situations. Where do they live? How easy it is for that patient to come back and get their follow-up appointments and injections. I think it's also smart medicine. And going back to the original point of the discussion, I think it's more resilient for the practice. As we increase and furthermore increase our rate of intravitreal injections, having opportunities to treat patients with non-intravitreal injections, decrease the volume of this, take this over here, and have a more balanced approach. I think it's good medicine, but it's also good business practices for our clinics. So that's what I have for now, and if you have any questions, I'm happy to entertain any discussions.
I think I heard you say that if a patient comes in with a great deal of edema, that you want to go with the anti-VEGF right away, and the rationale for doing that rather than The laser
Speed.
is, you want to get it down quickly, right?
Yes.
But I think I also heard you say that for patients who come in that have a much smaller amount of edema, maybe you just do the laser.
If the patient doesn't have
alone.
foveal involvement,
Okay.
then I'm not particularly stressed out about the timeline.
Mm-hmm.
The main reason that I want the timeline to be shortened is if the patient has foveal involvement, the central vision is compromised, anti-VEGF will be faster
Right.
at drying out the fovea.
Right. So it sounds like it's important to try to get these patients in to see you and your colleagues sooner rather than later. So
Oh, absolutely.
Uh-huh.
Absolutely. You're always better off treating something that is not too severe versus treating something that that's a simple
Right.
explanation.
Right. And one last question: what are the symptoms when if with this early stage edema?
Could be none.
Okay, a big problem like glaucoma, right? I mean, the
Yeah,
high IOP.
it could be none. This patient is 20/20. It may completely be asymptomatic, but that does not require us to avoid treatment.
And on a routine eye exam, does this edema show up? I mean, can the optometrist say, "Hey, you need to see an
A
ophthalmologist"?
good optometrist with a good OCT, which is not every optometrist.
Oh, for sure.
Yeah.
Uh huh. Okay. Thank you very much.
Thank you, guys.
Hey, Dr. Calzada, what defines significant reduction in edema? And at what point are you looking at central macular thickness before you laser, or try to get the swelling down to a certain point before you laser?
That's an interesting question. So I usually do not stress too much numbers. If you're working on a protocol base, say like a clinical trial, you will require to have some brackets and say, okay, it has to be above this, below this, and this location. And those brackets are important when you're doing protocols and studies. When you're in practice, it can just be a gestalt. You can just basically look at it and say, that I can do that. You look at the FA, for example, and by the way, it does require you, in my personal opinion, I do like having angiography. That's a separate point. Some of my colleagues think that angiography is unnecessary. They just base it on the OCT. I feel a little bit better if I know what's happening on the leakage side. But your point is, I don't stress too much if it's this much or this much. For me, it becomes a sort of, is the fovea involved and not involved? If the fovea is not involved, is it less than half of the macula? Then that's an easy, usually, treatment for MicroPulse.
Because I know in previous studies, like with Dr. Medina over in Italy, he was saying if you got the swelling down in and around 400 microns, under 450 microns.
Where?
And then
in the central subfoveal?
Central subfoveal area,
Yeah.
FAZ,
Yeah.
whatever. Get it down to about 450 or less, and then MicroPulse through a series of anti-VEGFs and everything.
Yeah.
You get a better response with the laser than just trying to do something by itself.
One of the problems of MicroPulse when you administer it is because since you're not titrating to a specific biological response on the time, old school, so for example, PRP. When you do a PRP, you do titrate the power. And not every patient gets the same amount of energy delivery. When you do MicroPulse, you really don't have that ability because you don't see anything at the time of treatment. So embedded into that point may be that some patients require more power and some patients require less power. But we just at least I don't know that bracket where I said, okay, if the patient's more than 400 microns of thickness, maybe I should go to 800 milliwatts. And if the patient's less than 300, I can probably treat with 350 milliwatts. So that bracketing we don't know, but it makes sense. But clearly, less swelling means more potential to have absorption of the laser energy.
Are you doing a combination where inject today and maybe bring the patient in 10 days and then MicroPulse on top of it?
Yes.
But you don't do MicroPulse and laser the same day?
MicroPulse and injection the same day?
I'm sorry, MicroPulse
Yeah,
and
you
injection.
can. Yeah, you can, depending on the severity. So, as I said, if the patient drives 200 miles to see me, I'm probably going to do it in the same day. And then what I usually will do in that is I'll do the injection before the MicroPulse, just because sorry, the MicroPulse before the injection, just because I don't want to put the contact lens and the coupling agent, the Goniosol, right over a recently created wound. Usually, if the patient is from the community, I'll do the intravitreal injection, and I'll say come back in a couple of weeks, and we'll just do the laser at that time.
Because depending on the anti-VEGF that you use or steroid, within that 2 to 3 week period, they should see a little bit better vision.
You may have a little bit of improvement, absolutely,
Exactly.
and at least it kick-started. There's another thing, which is the 90-day global period. So, if you said, well, we'll do the MicroPulse today and do the intravitreal injection next visit, you may have a problem with billing. But if you flip it, you have no problem with billing.
So what fraction of your patients that come in and have this edema are diabetic or pre-diabetic? Is that the bulk? Is that a...
For me, it's the bulk.
Okay.
I also do MicroPulse for macular edema and vein occlusions. I don't think the response is quite as good as in diabetic macular edema. I don't know why. I think it's macular edema and vein occlusions can be much harder to treat. There's a lot more ischemia, but I still do it on certain patients. But clearly the optimal, sort of the best EC patient is the diabetic macular edema.
I heard a talk earlier today where the presenter showed some data on the incidence of diabetes and this, just tremendous increase in the percentage of population, the U.S. population.
I'm in the state of Mississippi. Diabetics are everywhere you go.
Right.
So we're accruing diabetics and growing diabetic, literally.
Right.
And so we're going to have more diabetics. And interesting thing is that we have a lot of, you walk through this venue here and you'll see a whole bunch of projects of early diagnosis of diabetic retinopathy.
That's different from edema. Sorry, pardon my ignorance, but it's that the diabetic retinopathy is
diabetic
separate
retinopathy.
from
Well,
edema?
diabetic retinopathy is the background where the diabetic macular edema happens. But my point is, so you have all these strategies, companies, clinics, trying to capture early diagnosis of diabetic retinopathy, which is the right thing to do for these patients. But once you've diagnosed them, now you have to treat them. You see what I mean? So as you improve your screening strategies and you diagnose more diabetics with diabetic retinopathy and diabetic macular edema, now what are you going to do?
Use the Iridex laser. Of course. Perfect answer.
I think from my perspective, the answer is everybody should be treated like they need to be treated. But clearly, if every one of those patients gets injections forever for the rest of the next 10 years, we may just break the bank. Yeah.
Thank you.
Thank you.
A director
Thank
at
you.
Iridex, there are 6 of us who are directors.
Wonderful.
I thought your talk was great. Really, thank you so very much. And especially